Good morning. Thank you for your time and joining me for this presentation of Standardizing Fall Risk Communication, a quality improvement project presented by myself, Emilie Magnon. I'm a bedside nurse on the Progressive Care Unit, or the PCU. This project aims to explore a communication issue that's been ongoing on my unit. We'll talk about the communication problem itself, the intervention proposed to solve this issue, and as well we also discuss evaluation methods to ensure the long-term success of this project. So communication, how does communication influence quality care? Well, communication is virtually continuous. Everyone on a hospital unit will be communicating with someone else at some point throughout their day. Nurses to nurses, nurses to doctors, doctors to patients, patients to their families, patients and their families to nurses and doctors. With this virtual element of communication, it's essential to safe patient care. And a particularly significant point of communication in a hospital is handoff report, when one nurse conveys sensitive patient information to the next nurse. It's a comprehensive yet concise overview of critical patient elements of patient care, such as the patient's situation, background, current assessment, plan of care, recommendations. So again, communication is performed by every member of the healthcare team. So what needs to change? What's the problem? Well, current handoff communication practices lack patient-specific detail. Currently, my unit utilizes a standardized report document that one nurse will utilize to document all of this essential patient care information. Unfortunately, the fall risk assessment of this document is very limited. It lacks standardization, it lacks patient-specific detail, and it creates opportunities for gaps in communication and increases the likelihood of miscommunication. It causes communication breakdown and an increased risk to patient safety. How can we fix it? Well, these current nurse report documents depend on vague terminology, specifically when discussing patient fall risk information. Not only is the terminology itself vague, but the physical space on the report sheet is very limited for this information. It hinders clear, comprehensive, and consistent communication. So what's the problem? Once again, vague, incomplete, and inconsistent communication of patient-specific fall risk information on the nurse report sheet document. What is this fall risk information? It indicates the use of bed alarms or chair alarms for this patient. Do they need a gait belt, a cane, or a walker to ambulate? Have they just had, perhaps maybe the patient has just had major surgery that's greatly altered their baseline mobility status? Are they independent? Can they walk back and forth to the restroom by themselves? Are they max assist? Do they need the assistance of one staff member or 5 to 6? Why is this such an issue on the PCU? Because patients on the PCU is a universal unit, meaning that one patient in one room can be an observational telemetry patient, and they could very well be next door to a patient just recovering from open heart surgery, and one single nurse may be caring for both of those patients. So that wide range in acuity, those drastically different baseline statuses for those patients may be very different and a little confusing to keep track of, especially when those patients may change, their status may change constantly throughout a shift. A sick patient may get better, a well patient may get sicker, and it gets confusing to keep all that information intact. Well, why does it matter? Why is this so important? Communication specifically. Communication breakdown is a contributing factor of 60% of all adverse events across all hospitals in the United States. It's a contributing factor to 24% of all patient safety incidents, and it's a direct cause of 13% of all patient safety incidents across all hospitals in the entire United States. This, excuse me. This affects patient safety as it increases the risk of harm, specifically due to patient falls. This also results in a lack of trust between patients and their healthcare providers and patients' families and their healthcare providers. It results in poor workflow performance from the nurses themselves. If a patient falls on a nurse's shift, they may be subject to disciplinary action depending on the nature of the fall. Was it preventable? Could this have been easily avoided by better communication? Injuries from fall may result in increased length of stay for that patient, creating a financial loss for the hospital. Once again, injury from falls and increased length of stay results in poorer patient outcomes. related to all of these incidents compiled into one. So what is the goal here? What is the goal of this entire project? We talked about the problem extensively. What are we trying to do? We are trying to promote clear, comprehensive, and consistent communication specifically regarding patient-specific fall risk information conveyed through nurse handoff report at shift change. What's the solution to this issue? Implementing a standardized communication tool in the form of a checklist into the nurse report document. Who does this benefit, this implementation? The nurses themselves by improving communication between one another, improving work satisfaction. The patients are benefited by having their safety well safeguarded. And what's the goal, the overall goal specifically for this project, for this communication tool? The goal is that within the allotted time frame between August of 2026 and January of 2027, the PCU will observe a 90% nursing compliance with the communication tool, which will improve current communication efficiency by 60%. When will this happen? The project will be first introduced to the nurses of the PCU in August 25th, 2026. The implementation will begin in October 5th of 2026, and the official evaluation will be conducted in January of 2027. So what does the evidence say? How do we know this is a legitimate issue and a legitimate solution, rather? Well, communication breakdown during nurse handoff report, a comprehensive literature review revealed that information is often omitted, miscommunicated, or inconsistently conveyed, not just in the PCU, but on hospital units worldwide. Contributing factors include interpersonal and environmental factors such as interruptions, inconsistent communication methods, time constraints, inadequate documentation practices, mental exhaustion, excessive workload, and a lack of standard communication guidelines. Information, unfortunately, is often exchanged insufficiently, inaccurately, and incompletely. What's the solution? Standardized communication tools improve handoff communication. Information, thanks to standardized communication tools, is conveyed clearly, completely, and consistently. It reduces communication insufficiencies and improves communication qualities. It reduces the concerns of this vague terminology, this ambiguity, the report inconsistency, and these interruptions as previously discussed. It not only improves the handoff process, but the quality of the information that is exchanged. How does this improved communication affect patients? It improves patient safety, well-being, and quality of patient care and clinical outcomes. It invokes positive perceptions of patient safety during handoff report from the nurses themselves. It enhances continuity and reliability of high-quality patient care. So what's the plan? What are we going to do with this information? Well, current handoff practices on the PCU, given the report sheets that we currently use, that this flow sheet on the left side of this PowerPoint will illustrate, a nurse starts their shift. They provide patient care, they assess fall risk, they document their interventions and assessment findings into their charting system. They also take this information and document it into the nursing report sheet in a very comprehensive yet concise manner. As you see here, is fall information documented appropriately? Regardless of the answer, the nurse is going to give handoff to the oncoming nurse. Is this information sufficient to implement necessary interventions? Regardless of the answer, yes or no, the report will be over and the shift is ended. There is no standard, consistent safeguarding of patient well-being because communication breakdown is so prevalent. As you can see, an example of our report sheets that we use on the right side of your screen, this highlighted area is for devices and activity. This is where all fall risk information would go. However, because these are open boxes without concise options to choose from, nurses type their responses to this, their patient information, at free will, which opens the door for inconsistent terminology to be utilized at this time. Devices may not mean cane, walker, or gait belt. It may mean critical care tools such as a temporary pacemaker or an LVAD, for example. Activity, some nurses will put ×1, some nurses put standby. Rarely are elements such as bed alarms and chair alarms included in this document, once again opening the doors for gaps in communication. So hence the need of the standardized communication fall risk checklist to improve this communication breakdown. Who will be responsible for implementing this checklist? Nursing leaders, the PCU director, clinical educator, nursing supervisor. They will be responsible for introducing the project to the staff, educating the staff on its proper use, distributing the revised report sheets that will now include this communication handoff tool, collecting feedback from the staff, as we discussed in a moment, and revising the plan as needed based on nursing feedback and audits of the report documents to assess for compliance, as we'll discuss in a moment as well. Charge nurses will provide routine education on the checklist as per nursing request on a shift-by-shift basis. The QI project leader will assist throughout the entire project from planning through implementation and evaluation. And of course, the bedside nurses of the PCU are the hands and feet of this project as they're the ones integrating this intervention in their day-to-day patient care. So what is this intervention exactly? It's this fall risk checklist that is extremely concise yet overwhelmingly comprehensive that looks at fall risk assessment tools for fall risk assessment elements of patient care. Assistance, are they independent? Are they standby? Does it need one person, two person? Is the use of a lift required? Does this patient need a walker, a cane, or a wheelchair to ambulate? Is the bed alarm or chair alarm activated on, off, or is it not needed at all? Is a gate belt needed for patient transfer? Extremely comprehensive, but very concise. None of these elements are included on our current report sheets. Where will this intervention take place? On the progressive care unit or the PCU, and when? As I said, this will be first introduced in August of 2026, implemented in October, and formally evaluated in January of 2027. So what's it going to take? What do we need to make this happen? There's virtually no financial loss, no financial cost to implement this project or maintain it. No new equipment is required. No new software is needed to revise these report sheets. These are pre-existing report documents that will simply be slightly revised. There's no cost to train the staff. The initial introduction of these report sheets and the formal staff training will take place, as well as the evaluation time as well to formally evaluate the success of the project will take place during two distinct previously scheduled unit-wide meetings. So these unit meetings are already scheduled. There is no need to have new times to train staff. Everything is already set up. This will simply be a docket on the list of topics to discuss for that meeting. So what challenges can we expect? Well, the most significant barrier to be expected from this project is a resistance to change from the nursing staff. Nurses are often hesitant to change if they perceive a project will require more of their time, more of their energy, if they perceive it as an added burden to their already very heavy workload. But that being said, what might be gained by this simple, cost-efficient intervention? We're considering improved communication methods, promoting patient safety, preventing patient falls, reducing financial loss for the hospital, avoiding prolonged length of stay, and improving performance measures for the entire facility. Nursing feedback for this project will assess many elements that we're discussing in a moment, but is an absolute vital tool for the success of this project, as feedback not only addresses current problems, but feedback taken therapeutically may actually create solutions. So how is the success going to be measured? Well, outcome measures will determine the clarity, consistency, and completeness of patient-specific fall risk information. This will be determined by auditing report documents weekly by the nursing leadership. They will evaluate whether the checklists are actually being filled out appropriately, completely, and patient-specific, if those interventions selected are appropriate for those patients. Process measured. Is the communication tool being utilized appropriately? Are those patient-specific boxes checked appropriately chosen for that patient? Once again, will be determined by auditing those report documents. Balancing measures will assess for unexpected consequences. This will be obtained by nursing feedback. A nursing feedback will Collecting nursing feedback will allow for insight into nursing perspectives on, does this increase their workload? Does revising this report sheet to include this checklist create new unforeseen gaps in the communication process? So we're progressing through this intervention. How do we track our progress? How do we know it's working? Once again, auditing the report sheets. This will evaluate the completeness and consistency of the fall risk communication checklist. It'll be a spreadsheet specifically designed for this project, and it will include the total number of report sheets reviewed, a minimum of 16 audits weekly, with 8 nurses interviewed weekly for the feedback. I'm sorry, I'm skipping ahead. The data to include here is the total number of report sheets, the weekly compliance percentages, and elements omitted from the checklist. Are they being filled out completely? Is this patient's necessary interventions being covered as a whole? Bedside nursing feedback will evaluate whether the fall risk communication process has improved. Is this intervention working? Do nurses feel satisfied for this? This feedback questionnaire will also be specifically designed for this project. And the data for this feedback will include the ease of use, quality of communication, suggested improvements from the nursing staff. Once again, if they identify a problem, they may also have a proposed solution, and any perceived barriers or concerns that may have been unforeseen by the designing team. So is it working? How do we determine if it's working? Once again, those weekly audits that will be collected over an approximate 14-week period will be compiled, and their compliance percentages of those documents, a minimum of 16 documents a week, will be put out over a spreadsheet that'll be presented in that January 2027 PCU department meeting. This is just a hypothetical graph with made up information just to illustrate the progress we hope to see with this intervention. So we've been successful. This change is therapeutic. It's excellent. How do we keep it going? Well, there are 3 key elements to keeping it going, and all 3 of those involve the nurses themselves, the bedside nurses, the hands and feet of implementation, the nurses ultimately responsible for integrating this tool into their day-to-day patient care. Nurse leaders, again, the unit director, nursing supervisor, they are the ones responsible for collecting those audits and those feedbacks. Based on that information, they can revise the checklist as needed. If there is, consistent concerns expressed, revisions can be made based on that feedback. They can then repeat the entire evaluation process as necessary until success is truly met. The clinical educator can incorporate this new checklist into new hire orientation. So when new nurses are being trained on the unit and they're specifically educated on the report documents the PCU uses, their attention can be drawn to this checklist. And what this is going to do is reinforce long-term learning and long-term success, because quality improvement is truly a continuous process. Once again, why does this all matter? What are we benefiting from this? Patients will benefit by safer communication practices, consistent care, reduced risk of missed safety information, and improved quality of care. Nurses, standardized handoff report processes, as we've learned from the literature review, boost workplace morale, protect them from disciplinary action, improve communication between shifts, and, like I said, improve workplace morale. The healthcare organization as a whole will promote patient safety initiatives. It'll reinforce a continuous culture of quality improvement by utilizing a sustainable process through audits and staff education at virtually no financial loss. So with all of this, this communication breakdown prolonged issue, well, this simple, does this intervention improve the clarity, completeness, and consistency of fall risk communication during nurse handoff report? Yes. Comprehensive nurse literature, extensive interviews by the nursing leadership staff, including the unit director and the clinical educator, and the bedside nurses themselves, interviews conducted by myself, all support the success of this project. I'd like to thank you for your time. I'm open for questions if there are any, but if not, once again, thank you for your time and consideration during this presentation of Standardizing Fall Risk Communication, presented by myself, Emilie Magnon.